All right, let's dive right into this rapid-fire explainer on clinical anesthesia. We're skipping the fluff and hitting the absolute highest yield scenarios you're going to face, starting right now with airway management.
So imagine you're staring down a notoriously difficult intubation. What's your absolute gold standard for securing that airway? Are we looking at A, a laryngeal mask, B, nasotracheal intubation, C, percutaneous cricothyroidotomy, D, intubation over a bronchoscope, or E, laryngoscopy? If you went with D, intubation over a bronchoscope, you nailed it. And here's why it matters. This is the controlled clinical gold standard. You're doing this on an awake, spontaneously breathing patient, which completely avoids that terrifying cannot intubate, cannot oxygenate scenario. Something like a percutaneous cricothyroidotomy, that's strictly a surgical rescue for when things have already hit the fan. Okay, let's pivot straight to the cardiovascular system. You've got a patient fresh out of neurosurgery, their vitals get wildly unstable, and the ECG shows ST segment elevations. Troponin I is raised. What's the best treatment option here? A, PCI, B, injection of streptokinase, C, injection of TPA, D, LMWH, or E, dual antiplatelets. The life-saving choice here is definitely A, primary PCI. Think about it. Systemic thrombolytic therapies like TPA are absolutely contraindicated right after neurosurgery. Giving those would risk a massive, likely fatal hemorrhage at the surgical site. PCI totally bypasses that bleeding risk while getting right in there to immediately optimize oxygenation and coronary perfusion. It's a total no-brainer. Moving on to a classic post-op complication, this time following spinal anesthesia. Your patient is ambulatory, but 4 days out, they complain of a severe headache that gets way worse when they stand up, but practically vanishes when they lie flat. No fever, though. What's the cause? A, subarachnoid hemorrhage. B, CSF leak. C, infection. D, meningitis. Or E, none of the above.
You probably guessed it. The answer is B, a CSF leak from the subarachnoid space. This is a textbook post-dural puncture headache, or PDPH. What's happening is that CSF is leaking through the tiny dural defect left by the spinal needle. When the patient stands up, gravity pulls the remaining fluid down, literally putting traction on those highly pain-sensitive meninges. The definitive fix? An epidural blood patch, where we use the patient's own blood to seal up that dural hole.
All right, so the patient safely makes it to the recovery room. What's one of the most common and honestly highly distressing complaints they might have? A, pain. B, agitation. C, nausea and vomiting. D, inability to breathe. Or E, shivering. The correct answer is C, nausea and vomiting. POM-V is incredibly common, affecting a staggering 20 to 40% of all general anesthesia patients. It's absolutely miserable for the patient. We typically head this off with selective 5-HT3 receptor antagonists and prophylactic corticosteroids like dexamethasone, usually given rated induction. Speaking of recovery, let's tackle pain management. We have a 48-year-old female post-hip replacement. She's on a PCA with morphine, getting a 2 mg dose with a 15-minute lockout. After a full day on max dose, she's still in severe pain. What is your next best step? A, stop the PCA and give IM morphine. B, add NSAID and paracetamol. C, decrease the lockout time. D, change to fentanyl. Or E, increase the morphine dose. The smartest move here is actually B, adding an NSAID and paracetamol. Before you blindly crank up the opioid dose or shorten that safety lockout window, you want to use multimodal analgesia. By adding scheduled non-opioid adjuvants, you're targeting completely different concurrent pain pathways. This gives you a really nice synergistic relief and, crucially, keeps total opioid requirements down, which powerfully protects your patient from respiratory depression. Sometimes, though, post-operative complications are systemic and quite rare. Picture a 34-year-old female post-laparoscopic cholecystectomy. She presents with jaundice, fever, myalgias, and a blanchable rash. Her labs show a TLC of 6,000 with 20% eosinophils, AST and ALT over 800, but an ALP that's totally normal. What's the diagnosis? A, infectious hepatitis. B, bile duct injury. C, cholangitis. D, Merizzi syndrome. Or E, halogen-induced hepatitis. The answer is E, halogen-induced hepatitis. The huge giveaway here is that 20% eosinophilia paired with a rash and acute fever. This definitely isn't just a mechanical bile duct injury. It's a severe, immunoallergic type 2 halogen-induced hepatotoxicity. It's rare, it's fulminant, and it's completely distinct from a mild, self-limiting type 1 reaction.
Plus, that massive spike in aminotransferases confirms acute hepatocellular necrosis.
Let's jump back into the OR for a second. Of the following cardiovascular parameters, which one is not considered a minimum basic requirement for monitoring? A. Blood pressure. B. ECG. C. Echocardiography. D. Oxygen saturation. Or E. End-tidal carbon dioxide.
If you said C, echocardiography, you are absolutely correct. Things like continuous ECG, non-invasive blood pressure, pulse oximetry, and end-tidal CO2, those are absolute non-negotiable mandates for every single routine case. But continuous transesophageal echocardiography, that's a highly advanced tool. We reserve that specifically for complex cardiac surgeries or patients who are already hemodynamically unstable.
Okay, pharmacology time. When it comes to neuromuscular blocking drugs, seconds literally save lives. Which of these muscle relaxants has the absolute quickest onset of action? A. Rocuronium, B. Atracurium, C. Succinylmethonium, D. Vecuronium, or E. Cisatracurium?
Succinylmethonium takes the crown here, so the answer is C. Because it's a depolarizing agent, it hits incredibly fast. We're talking 30 to 60 seconds. And it clears out rapidly too, thanks to plasma pseudocholinesterase. That unique profile is exactly why it's the undisputed champion for rapid sequence intubation, especially when you compare it to the slower, intermediate actions of drugs like rocuronium or atracurium.
But what happens when an underlying condition completely changes drug behavior? Let's say you have a 25-year-old male with myasthenia gravis. He took his oral neostigmine just an hour ago, but now he needs emergency surgery. Which of these drugs will have a much longer duration of action than you normally expect? A. Fospropofol, B. Propofol, C. Atracurium, D. Nalbuphine, or E. Tramadol?
The correct answer is C. Atracurium. The trap here is actually the neostigmine. Because it's an acetylcholinesterase inhibitor, the patient's synaptic clefts are just flooded with native acetylcholine right now. So when you introduce a non-depolarizing blocker like atracurium, it faces intense competition just to bind to the receptors. That completely alters its clearance and results in a prolonged, what we call a surmountable blockade.
Toxicity is another major hurdle we have to be ready for. Imagine an elderly patient pre-medicated with scopolamine and atropine eye drops suddenly becomes agitated, delirious, tachycardic, and profusely sweaty. What's your antidote? A. Pyridostigmine, B. Adrenaline, C. Noradrenaline, D. Physostigmine, or E. Neostigmine?
The answer is D. Physostigmine. You probably remember the classic anticholinergic toxidrome rhyme, blind as a bat, mad as a hatter, red as a beet, hot as a hare, dry as a bone. To reverse that central delirium, your antidote physically has to cross the blood-brain barrier. That rules out most quaternary options right away, leaving physostigmine. It's a tertiary amine, meaning it actually has the lipid solubility required to reach the brain. All right, moving from toxidromes to one of the most feared intraoperative emergencies. A 10-year-old boy is given an inhalational anesthetic and succinylcholine. Almost instantly, he becomes markedly febrile, his heart rate spikes to 160, and he produces dark red urine. What is your most appropriate first step in treatment? A. Pre-treat future surgeries. B. Administer inhalational agents. C. Give succinylcholine. D. Hyperventilate with 100% O2. Or E. Acidify the urine.
The answer is D. This child is in a full-blown malignant hyperthermia crisis. It's a catastrophic hypermetabolic cascade that rapidly depletes ATP. Once you've completely stopped the triggering agents, which is always step one, your immediate next move is to hyperventilate the patient with 100% oxygen at high flow. You have to satisfy that massive metabolic oxygen demand. Only after you do that do you reach for the IV dantrolene to block any further calcium release.
Let's wrap things up with arguably the most fundamental procedure of all, tube verification. When you intubate a patient on the table during induction, how do you definitively confirm the correct placement of the endotracheal tube? A. On-table chest X-ray. B. 5-point chest auscultation. C. Direct visualization. D. E2CO2 assessment. Or E. None of the above.
It all comes down to D. Continuous ETCO2 assessment. Visualizing a stable, sustained CO2 waveform across 4 to 6 consecutive breaths is your absolute gold standard here. It objectively proves tracheal positioning and, honestly, reliably outperforms auscultation, which can totally fool you if gas happens to enter the stomach. So, as we close out this rapid-fire explainer, I want to leave you with this thought. If the gold standard for verifying an airway objectively ensures survival, what other routine practices in medicine are we still trusting to subjective observation when an objective tool is readily available? Something to think about.